They are the initial start of the spectrum. Also, Riemer and Kiskel wrote this very, very important sentence. Let's read it together. Premorbid affective temperament types have important role in the clinical evolution of minor and major mood episodes, including the direction of the polarity and the symptom formation of active mood episode. They also significantly affect the long-term course and outcome, including suicidality and other forms of self-destructive behavior, such as substance abuse and eating disorder. The temperaments, in my personal experience with clinicians, distributed in 3 subgroups, even if the main current actually distributed in 5 subgroups, because I distributed the depressive, hyperthymic, and cyclothymic irritable temperament, putting together in the third subgroup the irritable and the soft and unstable as a consequence of the anxiety group of other colors that we can include. Because in this soft and stable subgroup of the psychothymic temperaments, there is always the instability of the mood. In the same study I talked before, these are the percentage and method from all these 423 patients with a high percentage of psychothymic temperament, 49%, and the hyperthymic 35%. Probably because I did this study in Italy. I live in north of Italy. You know that Italian as Greek as Spanish are very, very stable as the mood basic. So that these are the percentage I found. The somatization. This is the third essential point for the clinician. The chronic presence in the life of the patient of some somatization, above all colitis, gastritis, and migraine, should catch the attention of the psychiatrist and of the GPs also as key symptoms for an early diagnosis of bipolar spectrum disorder. Because very often this somatization we don't catch very, very clearly. This somatization disappeared during the months in which the pharmacological treatment of their bipolar mood disorder were established. And also in that study I talked before, this is the chart that describes the percentage of the somatization I found. Colitis 45%, gastritis 25%, migraine 80%, only 20% were not in somatization, 80% presented somatization. Everybody presented also muscular tensions, so that I did not insert in the chart. When you can find only one somatization, you needed to think about maybe this patient maybe have some of the subtypes of the spectrum. If you can find 2 somatization, you can be pretty sure that the patient, very probably they present some subtypes group of the bipolar spectrum. If you can find a patient with together colitis, gastritis, and migraine, you can be very sure that the patient present one of the subtypes diagnosis of the spectrum of bipolar. When the patient with bipolar mood disorder presents somatization, very often these symptoms are misdiagnosed or mistaken for somatic symptoms caused by organic disease, with the consequence of the use of a long series of blood and instrumental tests, often unuseless for the illness of the patient. What treatment? The clinician needs to take care and, if possible, to go to the recovery of the patient. The treatment will require spatial care, and the pharmacological treatment consists in a combination therapy between mood regulators and antidepressants. You can see how many mood regulators we can use depending from the subtypes of diagnosis, but it's very important to not use the benzodiazepine alone or benzodiazepine together, the antidepressant, both in order to avoid an increase in instability and the development of patient to the dysphoric misted states. This event, the Depression Day, we organized it in Europe, country by country, since 10 years, to inform, to prevent, to favorite the government action, to understand for clinicians, for population, this disease. Every year, this European Depression Day presents a team, a European team. This team of this year, as you can understand, focused from the economical problems of Europe, so that the annual theme is for this year, depression and economic recession, the depression at the workplace. This event will target psychiatrists, GPs, any other professionals, patient organizations, the general public. Several countries will participate, also the Greece this year by Kostas Fontourakis. I know you know him. Kostas Fontourakis is a member of the European Depression Association. This association is headquartered in Brussels. Anyway, everybody of you are invited to collaborate with these events in country by country, to participate, to do several meetings, cities by cities. This is the European poster. Every country can put their own language, their own personalized in this poster. This is, for example, the Italian poster. We put the concept of depression and the communication, depressione e comunicazione, depression and communication, be connected. We would like to also underline the essential to be connected with us, with our website, with our Facebook page, and so on. In concluding, the consequence of a lack of recognition and treatment of mood disorder can be higher risk of suicide, reduction in the expectation and quality of life, increase the loss of working days, increase the use of healthcare resources, including for concurrent disease. And finally, the mood can be chronic and the clinical picture can worsen. So that, three important points for the clinician. The bipolar spectrum needs to diagnose it correctly, to treat it adequately, to catch somatic symptoms as case symptoms for both and early diagnosis and disease exacerbation. Thank you for your attention. I would like to present, to show you a picture of the Neo Lake, a lake in the north of Italy. Near here there is headquartered our psychiatric study center. Headquarters is in Franciacorta, very nice countryside at the south of the Neo Lake, and the picture of we fall. Thank you very much.